Types of cancer pain. It can be nociceptive, non-nociceptive. Nociceptive is somatic, visceral. Non-nociceptive is neuropathic and psychogenic. Etiology of cancer pain can be tumor directly infiltrating the tissues or organs, or directly compressing the nerves, vessels, and organs. The tumor can be indirectly causing the cancer pain by due to infection, inflammation, or other causes like DVT and lymphedema, or it can be other medical illnesses. A pain assessment can be done verbally with the help of numerical ratings like 0 to 10. You tell the patient 0 means no pain, 10 means worse pain. So what could be their pain level? It can be categorical scale where you tell the patient mild, moderate, or severe, so they have to choose in one of these categories. And visual analog scale where there is facial expression from a happy face to a worse and crying face, so they have to choose what they are facing currently. Intubated or unconscious patients, we use behavioral scale pain scale, or a CPOT, that is a critical care pain observation tool. In dementia patient, there is PAINART scale. Now coming to WHO scale, WHO pain ladder. Step 1 is using non-opioids analgesics. Step 2 is using weak opioids. Step 3 is using strong opioids, oral or transdermal. Step 4 is using interventional methods like nerve block, epidurals, PCA pumps, neurolytic block therapy, and spinal stimulators. This is the whole WHO pain ladder. Now, among non-opioids, we have acetaminophen, NSAIDs, aspirin, ibuprofen, naproxen, ketorolac, diclofenac. These are the starting doses, and these are the max dose per day in mg. For example, acetaminophen starting will start at 500 mg, and 4000 mg is the maximum dose. Similarly, specific COX-2 inhibitors like celecoxib, for that also starting dose is 100. Coming to opioids, tramadol, weak opioids like codeine, hydrocodone, strong opioids like morphine, hydromorphone, methadone, fentanyl, and oxycodone. These are the starting doses, and these are the conversion factors. This is per oral conversion, this is IV conversion. These are the numbers that we have to convert from the one to the other opioid. Now, these are the adjuvants. Adjuvants can be steroids, antidepressants like amitriptyline, nortriptyline, venlafaxine, and duloxetine, anticonvulsants like gabapentin, pregabalin, carbamazepine, topicals like lidocaine, capsaicin, muscle relaxant like baclofen, cyclobenzaprine, and tizanidine. Also, ketamine can be used. Interventional methods like intraspinal opioid administration, intrathecally, epidurally, or implanted programmable pump. Nerve block like celiac plexus block, splanectomy, thoracic sympathectomy, percutaneous cementoplasty, vertebroplasty, kyphoplasty. Mechanism of action is mostly through action of mu, kappa, and delta receptors. So mu has mu1 and mu2, kappa has kappa1 and kappa3. Mu acts mostly as supraspinal analgesia, mu2 is spinal, kappa1 is spinal, kappa3 is supraspinal. These are only modest analgesia. Delta is supraspinal. Now, how do you start an opioid? Morphine is usually the first choice, and usually you will start with 5 to 1000 mgs for immediate release every 4 hours, for sustained release every 12 hours with the bowel regimen, because morphine causes constipation. So breakthrough dose is usually the total dose per day divided by 6. For example, if you take 120 mg is the total dose per day, the breakthrough dose will be divided by 6, that is 60 mg. And also conversion to other opioids, we can use conversion factor. Opioid side effects, the common ones are constipation, dry mouth, nausea, vomiting, sedations, and sweats. Less common ones are hallucinations, delirium, myoclonus seizures, pruritus, respiratory depression, urinary retention.